Good morning and welcome to our monthly webcast. I'm Samir Mehta, your moderator. This is session number 153. We begin today's transmission on a solemn note. It is to announce to you and to express our profound condolences for the passing away of one of the legends in interventional cardiology, Dr. Eduardo Sousa from Sao Paulo, Brazil. Dr. Sousa, probably all the coronary stenting and the drug-eluting stenting which we are doing, I think all of us owe our gratitude to Dr. Sousa, whose amazing efforts and vision at the hospital Dante Passaneses started this journey in partnership with the Cardiology Research Foundation. We send our condolences to Dr. Sousa's wife, Amanda Sousa, who made so many, probably Dr. Eduardo Sousa achievements may not have been possible without Amanda. To our condolences to the family, which is Dr. Amanda Sousa, to Dr. Abizaid, and also to our friends Dr. Fausto Ferres and Roberto Botello. With those words, once again, welcome to another to show you more and more chronic total occlusions. So today we have a pure retrograde approach to a CTO. With that introduction, let me take you to the cath lab where Dr. Kinney and Dr. Sharma are standing by. Samin, Anu, good morning to you and to your team.
Good morning, and clearly our DES field with the Cypher technology brought by the initial experiments by Sousa and showing that long-term results has an aneurysm formation and so. With that note, clearly there has been a lot of emphasis and request actually to do a CTO cases. And as you know, if of the 153-4 cases we have done quite a bit of CTOs, about 18. We were unsuccessful 2 times. So we want to get an appropriate case and go through the various techniques. So this case, which we are going to show today, was referred to us because failed outside, and Anu felt it's a great case for the retrograde. So with that note, we start our welcome again from the Mount Sinai Cath Lab to all our CCSU live viewers, and we can start our presentation now. These are our supporters. The same, nothing changed there. So this is a case as which you said 153, 59-year-old male. He presented with new onset angina and had a coronary CTA, which happened many times nowadays. And actually, I'll talk about the CTA in one of my points today in a didactic discussion. That screening test is becoming CTA, not the stress test. And it showed total occlusion of LAD. Patient has some hypertension and was symptomatic, so SEQ score 38 is low, 100 is normal, and no known CAD, good EF. Patient was on torvastatin, metoprolol, aspirin. Cath was done outside, 1 vessel disease, CTO, total, mid, fills both antegrade and retrograde. They tried to open antegrade and were unsuccessful. So with that note, we'll go to the angiogram, please. Yes.
Okay, so this is where we are. EDP was normal, actually low 10, normal LV function. This is the right coronary artery, essentially normal. You see that it's a septal that's filling the LAD. You can start seeing it. So always go to the RA view to understand. So we have a septal that is collateralizing the LAD.
Just a moment, pause there. What a lovely illustration and the point you have made between the LAO and the RAO. That is exactly what you have mentioned. The real guidance is through the RAO. Beautiful illustration.
Okay, and also for people who are taking boards, this picture can always come. You have the circle of Vucens. If you see there. The conus, which is the first artery that is going parallel to the catheter, goes around the PA and it forms a collateral through the septal. Usually it is not way further down, it's, like in the proximal LAD, but it's a beautiful collateral. That's a nice demonstration there. And this is where we are with the dual injection. Antegrades, always you do the feeder vessel first, and then you see the antegrade injection. So first the RCA, you see the distal vessel, and then you do the antegrade injection. So it is the mid LAD after the septal and a large diagonal. Going back to your JCTO score for the antegrade, you see that's a beak, and only thing that is no calcium, which is good. It's a long segment, more than 20 millimeters.
And
You know
failed
that.
PCI.
Yeah, failed
And
PCI.
so
So
become
already
three.
makes, yeah.
One of the questions I have for you is looking at the antegrade picture. I know this was failed at another institution, but you wouldn't have wanted another effort at antegrade itself?
So looking at that angiogram that they sent, they created multiple channels, because I think they tried multiple wires, multiple channels.
Perfect.
If we try again, we will go back to that channel, and our chance of, I think, retrograde may be harder. Like you saw in our last case that we tried antegrade, caused a lot of various dissection channels. Then
look, difficult case, Anu. You concentrate. Let's get this going with your absolutely finest skills, and Sameen will continue doing the didactics and educate the audience as to the relevance here.
Okay, let's go back to the slides, please. Yeah. So basically that is our goal now. Reattempt of the PCI of mid-LAD CTO via retrograde approach using RCS septal collaterals. So this case, because of dual antiplatelet therapy, because they added isotorbide, and it's appropriate. And before getting into this retrograde, wanted to show some guide wire, particularly for the retrograde CTO.
Yeah, so I think we have mentioned this guide wire app that came out end of last year. Again, all our apps are free, and feel free to download them either on your Android or on the iPhone. So just showing the CTO. So as soon as you enter, you will have to make a selection, CTO non-selective, and then when we go to CTO, you will start seeing all the wires. So again, you will see whether you want to go antegrade or retrograde, and these are the various wires that we have for the antegrade, which we have gone through this a few times. So here also I'm going to start using Fielder. Like I mentioned, you have to have few of these wires in your cath lab, and then you get familiar with each wires and keep using them so that you get good at it. And next, so Fielder is to reach the lesion, and then we will change the wires.
Delighted to welcome Dr. Farzad Shashansai. I may not have gotten the name correctly. He's joining us from Iran and loves the case which you have selected.
Beautiful. Good.
Keep going.
Yep.
Yeah, these are the various Fielder. These are the antegrade wires for escalation, which are the usual ones that we discuss. And I have told Astrato is the last one, which I think to be used antegrade. So coming to the retrograde, right? So what you need is septal surfing wires. So we used to, years ago, you would see that we have used what is called as Fielder FC. Again, same, they're polymer jacketed, and they have low steep load, but Asahi have come with this newer generation wire, cyan black, which is polymer jacketed, hydrophilic coating, tip load of 0.8, and then SUO 3, very easy to remember. Why it's called 3? Tip load is 0.3, very small tip load. So these are all hydrophilic. So you have very important hydrophilic. So I guess the cyan black probably has this advantage, polymer jacketed, hydrophilic, and tip load, and this is how they are. And these are the wires that we are going to be using. Once we have crossed the septal and reach, usually the distal cap is always softer, so hopefully this wire should take us. If not, we will change to some stiffer wire once we reach the LAD. But if we cross, then you need a 330 wire. This is the RG3. Again, it's a 3 gram tip load. That's how you remember, 3 gram tip load, RG3, and 330. So it's all 3, 3, 3, if you can remember it. So these are the wires that we have today. So, and since we are going retrograde, we are going to use a Corsair, and with Corsair, again, you need a longer Corsair, which is 150. Always remember that. There's 135, 150. We use 150 today, with the fielder for me to reach at the septal, and when I reach the septal, I'll change to probably cyan black.
Okay. So good. So these are the one you're using a Corsair Pro.
Yeah.
Others are Turnpike and the Fine Cross, which are there. Okay. So we're ready to go back to the Enjo, and let's come our both fellows, Ali and Shiv. Bagga.
Shiv has prepared since yesterday for this
Yes.
case, so
Good. Let's.
So
Okay.
Anu,
This is a Corsair.
just
Yeah.
to repeat here, for our friends in Iran, this is all free, no? They can just download it
Yeah.
and put it to their use.
100%, everything is free. If
Yeah.
they go to cardiologyapps.com, there are more apps there. Everything is free. And also we have a lot of cases here that we have described, which one, for which cases. A lot of things are there in that app.
All continuing in an endeavor to educate the physicians in interventional cardiology, the endeavor from Mount Sinai and from ccclivecases.org.
And show the last slide maybe. They can show, because there they put all the apps and simple. Can show the last slide before we go on? 1 second, because if they want to know,
here we have.
Cath
These
Lab,
are
So
the
this is the one they can put a Cath Lab app and cardiology app, sorry, www.cardiologyapps.com, and all kinds of apps are there, and they're all free. And
Wonderful.
they get update, and they can ask some questions also in some of them, right?
Yeah, they can always update, and many of them they can upload. Actually, in Octade we have a system where they can upload the OCT pictures and ask us questions, and we will always get back to them. What we keep getting a lot of questions, especially from India, with all the OCT pictures that they get. Yeah.
Okay. All right. So we are ready to now. This case we are going through the right. The guide is MPLATS 0.75.
Yeah, this is a AL 0.75 and a VL guide on the left side.
Left side.
And we have heparin. Our ACT is about 290.
Come closer, yeah. You may be injecting.
Yeah.
We can make our physician's picture slightly lower and fluoro bigger. Adjust the pictures a little bit. Make a fluoro further big, and physician picture slightly smaller, if they can do.
Yeah, we'll be able to regulate that. That's a remarkable observation and should help.
You want to go to RF view? What do you want to know? What did it did?
Come die.
What happened on the top? Okay, good.
This is the first septal. I want to put this septal picture on the.
And always keep showing the hemodynamics in the bottom. Yeah, let's play. So this is the one, sorry, the which septal we need to go.
Do I have an RAO there? This is the one. Yeah. Go to that view. 35. Oh.
Probably the second.
I'm going to try the second. Yeah, second or the second.
Anu, a question here has come for you. How does the Corsair compare with the Turnpike?
No, the Turnpike is also can be used for this. Like I mentioned, it's all what you get comfortable with and using with either of the two, but except the length is the one that you need to select, that they have to be longer.
The Turnpike comes the long length also or no? Yes. 150. Yeah, both are okay, good.
And there is another newer one, which I don't know how many people are familiar, the teleport.
Yeah. We use teleport also. Yeah. We are not used much in the coronaries, but we are used in the peripherals.
Right.
Go somewhere else. I want to change the
curve.
Yeah.
Okay. Change the curve. Which wire is this? So that
this
everybody.
This is still a fielder. Regular fielder.
Regular fielder, but what about we have those sand black?
Not yet, not yet. I want to
SU.
reach the septal
Okay.
and then
For septal surfing.
we have opened the cyan black.
Actually, one time
So
when
one thing what I do, I don't know if everybody, if you're paying attention, that I don't go on fluoro until I know I'm there, just to avoid unnecessary radiation there. Okay, now they're still going into the same little. Okay, uh-oh. Need a run through maybe. Okay, we go with the cyan black then. No, let me do the cyan black first.
we are trying to go into the PDA first, right?
No, we are in the PDA,
Yeah.
but there's this first septal that is probably easy to cannulate.
So where is this now? Let's say this.
Come die.
This is it?
No.
Advance your Corsair now.
This is not the first septal. This is the first septal, but may not be well connected. No, this is.
Okay. So you switch to cyan black. Tell the logic behind now.
No, cyan black is the same polymer, but the tip load is a little lighter than the fielder, regular fielder.
Okay. So hoping that it will go through the existing small channels.
Yeah, surfing. Go, take this out.
Okay. So we are going with a cyan black now. We have SUO3 also if need to be.
Or fielder FC. I can go back to fielder FC. Have fielder FC ready? Okay, now.
Anu, when you went back with the cyan black, did you also give it a wire shape a little different than the previous one?
No, just made a little,
more
not
curve?
a straight, you know, a lot of people don't make the curves. We make a lot of curves in these wires. So we made the curve.
Better direction.
Yeah, good.
I think this is going to that other third septal.
Yeah, will be a lot of PVCs which are normal.
Some die now.
Yeah, what about this?
Looks a totally different direction and more promising.
Once it goes, you just have to bring your Corsair further.
Get the fielder FC then. Now die there. I think it's going into the wrong.
Yeah, a lot of people give the injection through the Corsair to see which septal, but I never helped it, you know. Yeah. No, but once it goes further, what happens?
Going into something else. I want here it has to go up. Okay.
What you think the fielder XC would track there a little better than the cyan wire?
Because of thin tip.
Tip is yeah. You have the cyan black, right?
Yeah, this is one.
This is what we need to track. Got that? Okay, take it out.
Sorry.
Hemodynamics are absolutely
So far,
perfect.
so good. Yeah.
Yeah.
Now, what we are saying is, can we make this one? No.
So this is Fielder FC.
Philip, now you have exactly the right screens, their perfect orientations.
And now die.
So it's a Fielder FC now.
Need to be a little back with the Corsair, or you like it? Seems to be directing it.
Yeah, I think Corsair should come back, yes.
Yeah, a little bit.
This actually is not even going up.
So the Scion was doing
Black.
a much better job than what we.
Get me the cyan black. SO3, not black.
So that's a good one. So all the retrograde wires, Anu is demonstrating, and let's see which one works. So rather than persist on one wire, we are changing all. Give us that one now. SO3.
Last time we used Fielder, I mean fine cross. This I think would be trouble.
And fine cross?
No, we cannot, no.
We can use fine cross. But
Oh,
new.
cannot.
But don't have that strength.
Yeah.
Okay, so another curve. So 3. Good. Okay. If not, I think we go with the cyan black. Make sure you guys are ready with that.
With
So
the
they're showing the performance of all 5 different retrograde wires now.
Samin, we continue to hear from many operators from countries which you have to search on the on a map, and they all write all sorts of useful feedbacks. Here is a note which I think is worth reading out to you and to the audience. This is from Dr. Suhaib Kadura. He says he's a first year attending at St. Joseph's in Syracuse, New York. And he's had the pleasure of watching every single CCC live case, including the archives. And he mentions to both of you, I'm.
Wow. Again,
Many people compliment it, never anybody to say that he has watched each of the 153 cases. Unbelievable.
Wow.
Thank
well,
you,
he got
Dr.
a special
Kadura.
prize. Thank you.
Absolutely amazing. Absolutely.
Beautiful. And the question is always that this is the one, right?
No.
Yeah. No, this is it.
There we go. There we go.
Okay.
Absolutely.
Good.
Which was
Record
this
it,
the
record it.
Scion?
Yeah. No, this is SUO 3. So tell us why this works so beautifully.
Okay, can we take antegrade picture?
Yeah, let's take an antegrade picture. That wire is there. Yeah. You just need antegrade now. Listen.
Samin, just illustrates your point. Do not stuck on one wire. They are very different, behave very different,
and you have to do the retrograde also, so we know we are in the LAD.
And this one just
Don't
wrap
inject
through
here.
it.
Yep. So this one
Only
is
you,
SUO.
okay.
So I can tell you the SUO gets a plus.
You inject, not you. Okay.
Yeah. Good.
Good.
Very good. SUO black, SUO 3, not cyan black. SUO 3 made it. And just to say, one of the great advantage have been also. Yeah, that's okay.
We don't talk until we know this will be tracking.
Yeah. Okay. Now the process of advancing the Corsair through those septal channels.
Okay, now
You want
guide.
to hold the guide?
Yeah, somebody has to.
Okay, I'll hold the guide. Yeah, you go.
Can you people not take such a deep breath?
Yeah.
People always ask us about technology, and here is a perfect example that our backup center, which is located in Montreal, detected that my headphone was falling off a little bit. So I apologize if the audience may not have been able to hear our remarks, my remarks regarding our gratitude to Dr. Kadura, but
we actually also, you know, I was just going to say, we didn't hear it completely also. If you can say, what was his statement, it will be a good music to the ears.
Dr. Kadura, first year attending at St. Joseph in Syracuse, New York. I have had the pleasure of watching every single CCC cases, including the archives. I am forever grateful for the amazing educational experience. Thank you, Dr. Kinney, Dr. Sharma, and Dr. Mehta for doing this over the years.
Beautiful.
This truly is music.
Thank you. Thank you. Yes. Anu, in this one, if it doesn't go, you put a small balloon.
I mean, there's a risk of perforation only because I see how the septal is.
You're making progress though with the Corsair there.
Yeah. No. So this is the case. If you want to see it, maybe
and we also see Dr. Kinney's hands exactly to coordinate, to demonstrate the fine clockwise, counterclockwise movements as the Corsair is being advanced very slowly.
Yep.
Samin, you were mentioning something?
Yeah, so no, same thing, showing that we are showing all these devices. If this does not go, we have the turnpike ready to see, because we showed various wires retrograde, and then we go with the retrograde catheter, and then of course we'll get the long wire to exchange. But so we have the turnpike ready. Yeah.
Why would you? What do you think is there about the turnpike which would?
Yeah, turnpike is the profile. Profile is much smaller.
Got it.
Just because of the profile, and then you kind of same way, the work with the same way corkscrew mechanism. But so we do use turnpike. I mean, I'm not a big fan of it, but a lot of people love it in our lab.
Got it. Got it.
But I'm still Corsair guy. But yes, turnpike is another device which is user friendly, and biggest thing is the tip, much lower tip. Profile. Good.
In the meantime, I hope that the viewers have noticed the importance of selecting the proper guiding catheter.
Yes.
I know before we went live, Dr. Kinney was talking about the AL 0.75 versus AR2. I think this was an excellent choice.
You want to give a retrograde injection again? Good.
Okay, so I think I can change the wire now, because this wire.
No, but it's okay,
so
you're
soft.
there. Yeah, you'll make it.
No, it's not. You already saw it was getting. No, I'm there, but I need to change the wire now.
Okay.
Okay, now, get me the.
Could you run through wire now?
No. You have to still go through the CTO.
So good, we are in the LED now.
I know, we have to go through the CTO.
But okay, you went in the LED.
Okay, give me the, which wire, Miracle or Gaia?
No, but you are in the, okay.
Yeah, we have to change the wire.
Yeah. Good. We still have to go back, penetrate the retrograde cap.
Huh? Yeah, Gaia 3 versus.
So
Miracle,
Anu, the three wires, if going back to how we had kind of started this case.
No, we start with the fielder.
No,
then
right.
Yeah. The
No, I
first
thought
is,
at this moment, the three
yeah.
wires to consider would be a Gaia, Miracle, and a Confianza. Or would you go
No,
back to the
I
Fielder
actually
XT?
would want the miracle, but I'm
Mhm.
not sure with all this curly Q thing that would, because it's a old generation wire, one-to-one torque is not there. It's not a good hydrophilic coating compared to newer generation. So I guess I'm taking a Gaia 3 now.
Excellent.
Let's see.
Like
You
your
see that how the,
explanation and
how
the
the,
distal
it's
part
not
was
sitting. Yeah.
very curly, which we
You see
didn't
that it will
appreciate
give
it
us into the
before.
subintimal. Already facing into the subintimal stuff. Okay, take it out. Okay. See, I don't like the tip of the courser facing into one part of the vessel, which could lead us to subintimal.
Would it help to slightly back off, come back with the Corsair?
I'll see, I'll get the wire there and then come back.
Then decide. But a lovely illustration of septal surfing, the crossing, the manipulations with the
Various
Corsair.
wires.
Yeah, exactly the kind of things you
Okay,
want to
give me
teach in
some
a case
antegrade,
like this.
antegrade.
And SUO3
Right.
is the one key. So now you go to different view to see the antegrade.
Go cranial.
Yeah. Go to cranial. Good. Look at this. Gaia 3. Record everything.
Unbelievable progress.
Beautiful. Yeah.
I just instinctively picking up the perfect wire.
Now we can do
Yeah,
antegrade
what are
injection,
you
right?
doing? Go back to the same view.
Yeah. No, not this one. This one, yeah.
Go to this view.
Okay. RAO 16, cranial 32. This is it.
So important, such small little things, they matter. Exactly the same view you want so that it guides you perfectly.
Yeah.
I mean, you pick up a different view here and then it resets you in a...
Antegrade die. Yeah, we are in the
Perfect,
LAD.
perfect. Good. There you go.
All right, beautiful.
What a wonderful job, Anu. What a wonderful job.
Good.
Okay,
now we got into the guide. Also. Okay.
Yeah,
and let's go to...
Just the selection of picking up, we were just talking about it. Why would you pick up this, and your explanation why you did not, truly to me, I don't know how the outcome of the case is going to be, but I think your explanation and your reason to have chosen Gaia
2.5. Yeah, 2.5 balloon.
And you explained it so nicely that, it doesn't really have the one-to-one torque, and the sum of the newer wires will offer you more, which is what it did. Experience demonstrated in an outstanding case.
You had once told me, Samir, the algorithm that works in my brain, if we could duplicate it.
Right. It is an endeavor of CCC live cases, even if we are not able to duplicate it ever, which is not humanly possible, but just to have them understand. And I am actually quite glad that just before you went onto the wire, I asked you the reason, and you mentioned it so eloquently and so perfectly. That is your thinking, which is how I think a CTO should be approached. You are kind of staying ahead of the game, trying to think that, look, this is not going as Samin had mentioned, that the Scion wire and the previous Fielder XC were not working. He says, don't waste your time. Move quickly to another wire, and that turned out to be exceptional.
Yeah, now we have
anchored the, I don't know if you can see it, I'm going cine, we've anchored, so the wire went very easy into the guide. I don't know, the couple of times we have shown, many times it's not that easy to get into the guide.
We saw it very nicely, and we are viewing it perfectly.
This was coaxial, and it was we were able to. So now for the use, it was not easy to track the Corsair, but so what you do is you go gentle. I'm advancing. If you're seeing my finger movements, yes. And what is happening? See, the guide is getting sucked into the left main, but that's okay. Leave it like that. So the wire has been anchored, and now, yes, let it guide. Hopefully we are good.
But now guide can come out a little bit, yeah. But our Corsair has gone.
Yeah. very tight. I guess you have to leave it like that, right?
I mean, the Corsair did a
Corsair is already.
fantastic job. What a amazing and a exceptional demonstration
So
of
you
a
see,
seal.
can you see that? I'm very close to the balloon now. The balloon anchored the wire, so that way Corsair went in. So now this was a little aggressive movement because the guide was deeply sucked in. Yeah, you can see the Corsair. So come down with the balloon. So now we will change to 330 RG. RG3, again same, I mentioned, how do you remember 333? So now
First we
this
take the
one will
balloon
come,
out.
yeah, this balloon will come out.
Okay. So anchor balloon is coming out now.
So when you take it out, there could be air trapped.
Yeah.
We'll suck that
And
out.
even the guide can be sucked in.
Yep.
Yeah, yeah. So far you see, can you, yeah, hemodynamics are okay.
Guide has to come in now.
Yeah.
There's not much support on the guide.
How did that come out?
Very fine movement again.
Yeah.
Good.
So these are very gentle movements. You have to be very cautious when all these things happen. So good. So now what I'm going to do is I'm going to take this Gaia 3 out, and then I'm going to go with the RG3 into the Corsair.
RG3 330, right? Yeah. Good. I don't need much.
Did you put in the water?
Yeah. Good.
We need that balloon again to trap it, okay?
Does the RG3 also have a hydrophilic component to it?
I don't know. Go back to that slide of RG3.
Yeah, we need to learn a little more on
Because
that.
when you mentioned about putting it in the water, I thought that was the reason you're trying to increase
actually
its
keep all
gliding.
the wires in
Every
water.
wires are in the water. Only thing is, I think this is a very, not a lot of.
Where is RG3?
Remember, we always use wiper. Little floppy
And the
wire.
other one is the wiper, which we used to
You
use.
think
No,
this
show
will be
the, what show this today.
Don't
So
show
we have
this
done
today,
in
we
the
never-
past, we have shown the,
Viper.
no, what is this?
This is RG3? Yeah. What did you give me before?
You just made the curve. Yeah, good.
Did you clean it?
Yeah, so key is that in the past we have shown the viper. And viper 0.014 separate.
Yeah, this is not 1.4. This is 1. Can you go back with the slide there? Can you make it bigger? Take the hemo out.
Philip, remove the hemodynamics. Okay, there you go. Perfect job. Beautiful job.
Yeah, that's what it is. Is that hydrophilic coating?
It writes only,
Yes, I'm worried about this.
yes,
Coating is hydrophilic, yeah.
It's very thin.
Yeah, but that's
Distal
okay, let's try it. That's everybody
hydrophilic
uses.
with the body hydrophobic.
No, but everybody uses RG3. Let's see if it works or not. So what Anu is concerned, that it looks like a very flimsy wire compared to our
It's not a question it'll work or no. Halfway through, we cannot change the wire.
Pick up your, you prefer the Viper, you said?
No, that's what
there are
we
three
used
companies,
a lot.
right? There's one more exchange length of this kind. Okay. Let's get the wire. Where is it now? Let's come out? No. No, this is not exchange length. What wire they gave you?
This is not. Give me the. This is some.
No,
other
where is the
wire.
RG3 wire?
No, this is not 300. 330.
Unless it has moved all the way.
Cannot be.
Yeah. Yes.
Hmm?
Yes,
Yeah?
yes. Go, yeah. Yeah, this is actually wire has gone all the way, maybe ready to come out from other femoral artery.
Is it black?
It came out.
Oh, yeah.
Yes. But very nice.
Oh, yeah.
Advance, yeah.
Okay, now. Okay,
Went
see
up. Yeah, see that? Going up.
Can you see it on
Yeah.
Not
Are you able
very,
to see?
The top.
not
Okay,
very
here.
clear.
Okay. You see where the guide of the left side is,
Now see
and
that.
that's where we are. You see it? Now moving up.
Yeah.
Yeah.
You saw that?
Yep.
Yes, now we do.
Okay. Okay, good. So, can we see the retrograde coming down? Okay, now it's coming down. Do you see it? I'm going cine again. You can see it going down.
Yep. Right there. In the center. We want to go AP now.
Yeah, go AP.
Okay.
Okay, so maybe it's better than the other one.
Yeah. It's moving
So it's
very
definitely
nice.
hydrophilic coating.
Saw that. Okay.
Okay, now I want the camera here focused. The wire will be coming out shortly. Okay,
And you
it's
put a
already
needle.
here. Yeah.
Needle.
Yeah. Okay.
Yeah, the wire is coming out. You're seeing it. Yeah, it's there.
So now what I do, anybody, can you see on the top?
Yeah, they can see the wire. Yeah.
Samir, are you able to see it?
No, but go through this.
Yeah.
Right.
Yeah. Yeah. The new Y connectors. It's like there's not enough room.
Yeah.
Hmm? You want to put a more wire? 1 second.
Yeah. Go.
Yeah. Good now.
No, not enough.
Oh, we can do more wire.
Not the question. I think we made too much curve. Now this has to go through this. Much easier.
So what happened is we don't have other Y connectors because this Y connector doesn't allow any length.
Cannot.
All the Y connectors are gone. Yeah, here, go. You know, there is a big shortage of the co-pilot and other Y connectors. Boston Scientific, Abbott.
Global supply demand issues.
Give it. Oh, this is, forget, this is longer than other. Yeah, let me,
You want to do it?
no? You want a little light?
No, I can see it. It is like needling the thread. Threading the needle. Okay, wait, don't touch it.
Good.
Okay, successful. This should not be this difficult.
Okay, good. Yeah. But
Completely
this is just because of the
externalized here.
Yeah. Good. Okay.
So this was
Now we go with the
the
balloon.
Viper or the RG3?
RG3. We kept RG3.
Okay,
Very
it
good.
runs.
Good.
It's coming out easy.
Anu, what,
Yep.
2.0 or
Which one?
what
three.
balloon are
Three.
you proceeding?
Balloon
Straight
is
No,
with
two.
now
three?
we will
Straight
go
with
with the
three?
two.
Two
Yeah,
balloon,
two
two balloon,
Yeah,
not
yeah,
two
that's
balloon.
what I
So now
thought.
very
Yeah.
important now this Corsair has to come out.
Yep. No, two balloon we have, right? No, but this is to take this
This
out.
is 2.5. Get me a new 2 balloon. What did you open? Okay, good. So now, are the
Corsair
steps
coming
clear?
out.
I don't want to be as the steps clear. Corsair is coming out.
Yep.
You'll also come back a little with the
Guide.
No, guide is coming out.
AL
Yeah. You
0.75.
have to start coming out. Yeah. I'm coming out with a guide. Good.
And you're withdrawing
Okay, it's
the
coming out.
Corsair.
Yeah. It's good. Keep going. Coming out. Good. Coming out.
Okay.
Guide is deep in. That's
holding
okay.
the
Let
wire,
it
right?
go. Yes, I'm
I
holding the
can
wire.
just pull.
Yeah, leave it there. Don't pull it completely.
Yeah,
Remember
okay.
it.
Good. Yeah.
Anu, why do you want to still leave it there though?
Yeah.
Why can it not come out?
No, we have to change it to the antegrade. No, we have to get the antegrade wire. You have to dilate, get the antegrade wire. We have to dilate. Yeah,
Okay.
yeah. Don't. I think we took it.
This is a day
No.
of Samin getting
No, but
some
point is if
amazing-
this comes out, yeah.
Does
I'll
not
let
come
you.
out that easy.
No, but we can put a wire through this now.
Not here, through here. You have to get the balloon here. That's okay.
Okay.
Then this wire has to come out
Right.
at
Yep.
one stage. Yeah. So
Yeah.
you cannot take it out.
Okay.
You took it out?
No, this wire, you have to hold it, so advance a little bit.
Yeah. Cannot.
But it's just a little bit there.
You cannot take that because we got go antegrade.
Your guide is coming out there.
Now it's come out.
Wait.
It was too much in one time.
Right.
Yeah.
Overcompensation.
Yeah, there. You're
Samin,
holding
this is a remarkable day today. I mean, not only did we receive such a lovely note from
You
Dr.
have to hold this
Kadura,
wire before it goes. Yeah. Yep.
I
Good. We have it.
Okay, hold it.
So we have both the wires now. Yeah.
So Samin, with both wires secured, let me make it even a lovelier day for
Good.
us. This is
Okay,
a
what do we
note
do?
from Dr. Andrew Verbenko.
Keep going. Yes.
So Dr.
Antegrade
Verbenko
picture.
writes, hi everyone, working radiologist for 5 years in Russia, and remember how study bifurcation stenting by our great videos 3 years ago. Thank you. Your moves make people. Wow, that is amazing. Dr. Verbenko, thank you for your thoughts and good wishes, and I'm glad you are following the cases
Let's dilate on this
so
one.
closely.
Then you have to go antegrade wire. Then we take this out. Okay, get me a 2.
You have to cut it then.
Yeah, understood?
You have to cut here.
No need. It'll go, hopefully go.
Okay.
Okay, cut. Cut. This one. Hold it.
Okay.
Give me. So I'm going to go on the RG3
with the 2O balloon.
Yeah. Going antegrade now.
Now, of course, Anu, some people could even, it's such a long wire, a little harder, but you could even do this without cutting, no?
No, soft, because of
Right.
soft end.
Right.
Because it will not go.
On
So
the
other,
stiffer part, yeah. Okay.
Yeah, yeah. So that's the only one issue remain. Good. So you
get me a run through wire.
Little, spring coil, but you just have to cut the spring. Good. So we have 2O balloon now. And then once you put an antegrade wire side by side, then there is not an issue at all. Don't avoid, a lot of people do a case, this technique, that technique.
Some dye, just make sure we're not in the septal. Antegrade, yeah. Good.
We have to go to the view now. 1 second.
Okay, good.
Let's go to the view. No,
Go
1 second. We
That's
have
good.
got.
Go up. We're okay.
Okay. Our view was 1632.
Okay.
Good.
Go up. Go up.
Yeah. Okay.
Okay. Go up. Okay.
Good.
Go up. Good. Down. Up here.
Yeah. Yep. Going up. This is the 2O balloon. Compliant. Okay.
Anu, your first inflation, was it not too distal? Or you deliberately wanted to cover that part?
I have to, I mean, that's why we went to the same U. Probably it's okay.
Right.
Yeah.
And
down.
very low inflation. You didn't.
Yeah. So we are
And
good.
2O balloon. Yeah.
Get
Let's dilate ostium.
antegrade channel there.
I think we are good.
Yeah,
Yeah, we're good.
No,
Go.
pull back a little bit more. Yeah. Good.
Okay, good. Down.
Now, a lot of people will do now that exchange this wire and, like kiss technique, kissing tube over the wire system, which we have done in the past also. Once you're done, try to put a wire antegrade, if you can do. You want to try antegrade? What is the plan now?
Okay, get me a run through wire. No, I think let's dilate more, right?
Yeah, you need to, I think, get a little more flow there.
That 2.5.
We are 2.5 already.
Or you want a 3.0?
No, 2.5. 2.5.
And then we go antegrade wire.
Yeah.
We are 2.5. Yeah, that's fine. Yeah, that's fine.
Pull like that.
We'll be okay. Yeah. Let's see. It's okay.
Can you get a better balloon?
You want 20 then? You want 20? 2.5, 20?
No need. Let me see. Not easy to get this balloon on this broken wire.
LAD. Get a 2.5, 20 then. Non-compliant.
Run through is ready if I need. And we have a fielder, right?
Okay, this is the 2.520. We are going antegrade. It's still on the same RG3.
I'm going to go all the way down.
Yeah.
A little bit into the septal. Okay, go up.
It's very little.
I'm a little bit into the septal. Go up.
But you don't want much because
Okay,
LED is
down.
still further down.
I know.
Yeah. Okay.
Go up here. Good.
Yeah,
now we.
Anu, why did you go a little into the septal with this large balloon?
See how the disease is. The disease, we went into the third septal, and then it extends further down.
Got it.
So I just want, okay, okay, good, go up. But I think the tight lesion, we just cracked it.
Right, this is the real area, I think.
I mean, septal is okay to dilate a little bit. It was only 2.5 balloon. We didn't go high pressure, but only the tip. Okay, antegrade, and then. Okay, now we see the LED. Now we can go side by side.
Yeah, definitely.
And then we take the other wire out.
With the run through?
Yeah, run through.
Run through.
Yeah.
Now, for some people will do that. You have exteriorized that. Now you go back that antegrade. You can put another catheter.
Yeah.
Over the wire system.
No, that's actually
so that become like kissing. You already have your corsair.
That's the way you remove it.
You go to antegrade and then you take the wire out.
Fine cross.
Yeah.
To remove it, you have to do that.
Yep.
Otherwise, you will have cheese nice effect of the vessels. We just want to wire antegrade.
Okay. So we are going with the antegrade wiring now.
Very nice job with that. There was a little intimal disruption there, but and
now I think we should pull back the corsair. I think we are in the septal, but there's not much room.
Right. Maybe a little more shape to that wire.
Good.
Yeah, the thing is take a fine cross and go with the fine cross. Some die and
that's a little die here, antegrade.
Here we go, almost there.
Could be subintimal, I think. Get me fine cross. Okay, now, no, subintimal.
Right at the point where it exits out.
Yeah.
Now we are good.
Yeah.
Antegrade die. Now we are in the LED.
So what did you do different there?
Pull back in the little different channel.
You know, went into the channel. And I went, look now, I'm so parallel to that wire.
Exactly, it was the same wire. You didn't change.
And I did not change. But the thing is same. I came all the way back.
I think it just needed to be scared that you're bringing in the fine cross. Just the statement helped.
We can still take that
at 2.5. I always have these things. Same wire, different technique a little bit.
Okay, now let's go to the step by step how we are going to take our existing wire. So now, procedure point of view, we have done an antegrade wiring. Now we have to just take our corsair out and the second wire out.
Fine cross.
But how you, okay?
So, no, nothing, you keep going inside.
Okay.
You flushed it?
Yeah. So here is the movement of the wire, just because there's so much tension in the system can cause the longitudinal cut into the vessel. So what you want to do is you want to cover that areas which the wire will be moving. So here we have one corsair already there, and second, now we are getting fine cross.
You kiss it. So I'm going to go forward with, I'm just going.
Yeah.
Is the top camera working?
Yeah, working, showing in, but show the fluoro also that you are going with this.
No, I know.
Yeah.
When I'm ready.
Yep.
So always the rule is that when you are at the knee of the patient, that means the wire should be coming out. Okay. Is the wire come out? Yeah, you have it.
Yep.
You see that the wire is out. So now I'm going all the way.
Here.
See there? So now we are kissing.
Good.
You see that? Now both are kissed. Both are together. So now what I'll do is I will take this RG3, but leave it. Let go.
Yep.
So RG3 is coming out.
So RG3 being pulled out from.
Wait, don't. I have to take out this. See the RG3 is coming out. Can you see it on fluoro?
Right.
Yes.
And that's.
Guide is deep in. Yeah, came out. Good. Everything is out.
And Corsair is out now.
Yes. Now let's make sure RCA is okay.
Good.
We take out that guide.
And we can remove. No, but you want to remove this now because there's nothing there.
Corsair is out.
Yeah. Good.
All
have been removed.
Closing picture of the right, no, at this stage?
Yeah. Yep. Definitely. We are going to go to different view. If
RAO.
Yeah. Don't keep giving die, guys. Fellows, they keep like die.
Good.
Looks good. So that
Perfect.
is coming out.
Yeah.
So now we go dilate antegrade and put a stent. Yeah.
The main right moment for you to start your
discussion. Yeah. This is the key. But just to emphasize once again,
just about every
one step
aspect
watch
of the,
every aspect, particularly removing your wires, right? I mean the region to go with the antegrade fine cross.
Yeah, it's called the cheese knife. That essentially, if we had just done pulling out, the wire can actually cut the vessel, which is the native vessel, the septals, and all this. So that is why I think RG3 actually is a good wire. You saw that?
Yeah.
Hydrophilic and very good. So antegrade picture.
And that is why people like that for this purpose.
Okay. So LED looks good. So we're just going to dilate and probably we need 2 long stents.
2 long stents. Okay. All right. So with that note, we can go. You want to use synergy? But no, what did we do? Synergy in this case or anyone?
No, yes, nothing.
Okay. Good. So let's go to presentation. And while we are going to, and we'll come back now, the whole case is done. So what I'm going to show.
In the meantime, without naming, there are at least 5 or 6 viewers who have mentioned and thanked both of you to have taught them many new tricks in this remarkable case.
And we will have more CTOs coming because I know that we have trained, I think, everybody on the calcific lesion, bifurcation, left mains. We still a lot of demands about the CTOs. And actually one of the retrograde CTO is like 4th highest viewed our cases. The one of the biggest viewed is like almost 50,000 views on a bifurcation calcific LED diagonal bifurcation. It's like 50,000 views. But CTO
I'm
definitely.
willing to bet this will have a huge following. This particular case, I think, is probably one of the best teaching cases we've had.
Absolutely.
So far,
okay.
We don't want to jinx it. The case is not done yet, but
yeah. So now it's I mean, again, we say that now it's simpler. So what I'm going to do quickly is we always update. Next month will be the ACC. We have the lid breaking trials. So before that, I have few publications in last 3-4 months. We want everybody to keep very precise. I'll just go with the slides quickly. And one of the big advantage, which a lot of people have said, that PowerPoint slide download, not a PDF. PowerPoint slide, many times you go to various websites, they ask you for this subscription, this money, that, nothing. All free, all the slides are in the PowerPoint, not PDF. So what I'm going to speak about is the 4 data recently on the defined PCI trial, 1-year follow-up. Then I was guided PCI for long lesion, 3-year. Predictors of left main CAD in ischemia trial, very important paper. And lastly, the side branch wire in COBIS 3 registry. We keep talking about should we jail the wire in a 1 stent technique. The focus review of the month will be, last month we talked about the complexity of the lesion, the chip score. And now we have another paper came out in circulation intervention is the PCI operator profiles and outcome for PCI operator profile and associated in-hospital mortality. So with note, we start our first one is the 1-year defined PCI trial. Remember the defined PCI trial was, what they did is they did a PCI and they did IFR in the end. As you can see, you start with a 0.69, post was 0.93, but many patients, you see that, below 0.89, 24%. Yeah, 24% of the patients had the lower, the FFR of less than 0.89. So that's the key, or 0.90. So very important. That majority was because of focal lesion. So clearly what we learned, 24-25% has a IFR of less, is still significant IFR. Of that, 75% is because of focal lesion. So concept is maybe by fixing that, you'll improve their outcome. And there is a global defined GPS trial ongoing to answer that question. So these guys gave the data of 1 year now, and they said that let's go to the better number, 0.95 IFR. So if you get to the IFR 0.95, that means you have done a very good results. And if IFR is less than 95, so you see here, 0.95 went to 182 patients and less than 0.95 in majority 285. So like 60-40 split. But outcome was 3 times better. If your IFR was more than 0.95, your outcome was much better, like 3 times lower, 1.8 versus 5.7, MI 1.1 versus 3.9. So clearly you want to have, and more importantly, look at the spontaneous MI. And so key remains, although revascularization did not differ. So overall, the message was that you try to get IFR of 0.95, and angina also improved in these patients with less than 0.95, and they put it together in a central illustration. So basically, very important that we need to successful PCI, not just by angiogram, maybe physiological, and you know that this field is still ongoing, that what is the value of the post PCI physiological, whether it's we are doing IFR or FFR, and defined GPS trial will show long-term data. Second one was 3-year cardiac survival after IVUS guided long DS implantation from 2 trials, Ultimate and Explore IVUS XPL, and they took the patients who have a lesion length of more than 28 and followed them, and you see 3-year there was a decrease in mortality as well as composite cardiac death, MI stent thrombosis significantly decreased, became half compared to non-IVUS guided PCI. So simple message, as you can see here, cardiac death, composite endpoint, the stent thrombosis and TLR all were significantly lower in the IVUS guided versus angiographic guidance. So this is same came with the optimize. Now also in the IVUS, once you optimize data, you do even further better. So not all IVUS are same. It's a IVUS optimization has a better outcome than just meeting the all IVUS, not optimized IVUS versus optimized IVUS has a totally 2 different outcomes. So clearly once you do IVUS, you need to have a optimized criteria of the IVUS. That's the only purpose when you're doing the IVUS and associated with the long, better 3-year cardiac survival. And then the very important was that which patient have a left main CAD. Patients who come to the CAD, we do a stress test. Can you predict the CAD based on your other non-invasive parameters in clinical in the ischemia trial? This was from the ischemia trial. Patient, as you remember, ischemia, anything less than more than 50% left main on the CTA were excluded. So what they did is the patient have a CTA and to see that whether patient has more than 50% left main and what were the subgroup in those cases. So basically left main more than 50% or left main, no left main more than 50%. As you see, the more than 50% was present in about 10%. So key is one thing we knew, patient comes for our further checkup for CAD, that you do about 10% will have a left main disease, around 10%. Second, based on the modality of the stress test, as you can see there, that whether you have a ETT or the segments, various entry ischemia, like going to the bottom there, that there is not much difference. Means it is there, but not a striking difference that you have severe ischemia, which will tell you that it's a left main disease. Slight difference. So what they went in, that exercise parameter after adjusting clinical factors, significant predictor of left main disease were old age, male sex, and lack of prior MI. Otherwise, exercise predictors were not very important predictors of significant left main disease. Then second point was in terms of the stress test, as you can see, there was greater ST segment depression, lower peak METs on ETT and ischemic dilatation, and nuclear imaging were not independently associated with the left main disease. So very clearly they talk about both SPECT, PET, echo, and ETT, that there is a wide variation, not full prediction of could be less than 2%, less than 30%, and they go to individual subgroups. And overall, the message is in this slide that patients who have left main disease, predictive probability of patient based on the stress test, female without severe ischemia or male or with severe ischemia, still remain low. And that was the conclusion of the paper was, then patient with a moderate to severe ischemia, clinical and stress testing parameters were weakly predictive of left main disease on CTA. For most patients with moderate or severe ischemia, anatomic imaging is needed to rule out left main disease. So key is that even you have a strongly positive stress test, it doesn't tell you you're left main or not. So clearly you need to do a stress test, just like as I mentioned our case, who just had a positive CTA and came to the cath lab with a total mid LAD. And they actually talk about that the non-visual assessment, okay, but not anywhere that you need to have anatomical imaging to diagnose the left main. And we know left main is the one which is associated with survival, 16% mortality at 1 year. So then question always came, you wire the side branch in a single stent technique, whether you should wire it or non-wire it. This is from COBIS 3 latest data, wire jailing versus non-wire jailing in about 45 and 55%. And you see here, we got some observation. So remember, we always believe you should leave the wire. And turns out to be that latest data with the latest generation stent, old data were there, that leaving the wire with a side branch may be beneficial. But in the current generation stents, you see side branch occlusion, not different whether you jailed or not. What was different was restoration of the side branch flow. After abrupt your side branch closed and you had a wire, you were able to maintain bring back the TIMI3 flow. Anything else? No change, angiographic procedural success in hospital MI and so, and also the wire breakage does not happen. We don't break the wire, any wire you use. And they actually have correlated that if your side branch or main branch has more than 60%, you have a higher chances of side branch occlusion, and wiring, jailing the side branch may help, and also the lesion length. So, but if you talk about the long-term event, they followed the patient for 6-7 years and they found no difference in terms of the follow-up, death, MI, and TLR. So with that note, I'm just going to come what they have done with the angiogram.
Samin, sure. Also one moment for a comment here I need to make regarding wire jailing. This is exactly what you have been talking and showing in all these cases, that don't worry with the newer generation DS, the wire jailing is not going to be an issue. Be sure that you leave the wire there just in case the vessel shuts down, you have an access.
Yeah, so question was twofold. One, is wire jailing itself keep your TIMI3 flow in the side branch? Answer, we learned that if a lesion is less than 60%, it doesn't help. If lesion is more than 60%, it helps keeping the patency of the side branch. So majority, if you take all bifurcation, based on the data, I would say that trial, the COBIS 3 registry of the jailed wire as a group is not beneficial. If your lesion is more than 60% in the side branch and the lesion length of the main vessel more than 10 millimeter, those cases, leaving the side branch keeps the vessel open. The second point which you mentioned, that once you close the vessel and your wire is in the side branch, you can restore the TIMI3 flow much higher % of cases versus if you did not have a wire in the side branch. And you wanted to say something? Yeah. Okay. So you want to show the angiogram?
Yeah, you can see the angiogram.
Yeah, let's see the angiogram now. Yeah, play.
Let it play. Yeah.
So what did you do?
No, we just dilated and we placed a stent.
Yeah. Say what stents were placed or what length?
It's 275/38, and then we put a short stent distally. That's it. Goal was, you see that we are proximal cap to distal cap coverage. So that's all we did. So if you see that, it was like the third septal onwards. So that's exactly where we are.
Anu,
The stent
exceptional
stops there.
result.
Yeah.
I was surprised. I thought you would have chosen a 3.0, but 275 is
No, we
absolutely
post-dilated.
perfect.
We
Okay, yeah, okay,
post-dilated
got
it
it,
with
got it.
3 to 22 atmospheres.
And
Yeah.
this was what stent were used here?
Promus.
Yeah, it's the Promus Elite. And look at the branches. Septals, they still remain. The septal which we went through is still there. Play again.
Pristine
it's a,
result, such
Yeah.
amazing skills,
Yeah.
so many teaching tips in this particular case. Anu, I know you want to complete your thoughts here. Just to let you know, here is another exceptional letter. This is written by your fellow from 2018, Sagar Reddy. And Sagar writes, hi, Dr. Sharma, Dr. Kinney, Dr. Mehta. I'm one of your former fellows, 2018,
Yep.
joining from the West Coast, still learning post-fellowship, exceptional skills on display. Thank you so much, Sagar. I think he particularly mentions it. These were absolutely outstanding skills. Such remarkable case, Anu.
Thank you.
Beautiful. No, really thank Sagar. We are proud of him. He has done tremendous job. Tremendous job. Okay, let's keep playing. He's in third year in practice, but they have done a tremendous. Let's quickly finish. The last point was the PCI operator profiles and outcome with in-hospital mortality. It's very interesting. So they did our machine learning. You know, we talk about how can you use artificial intelligence. So these authors took the data from ACC NCDR put 38 factors, not the hospital, not the insurance, but various points, as you can see there. I mean, of course, insurance is status, what patient is, but they did not count that in, but they have the data on. But all the procedural history, coronary treatment, whether what device do you use, whether atherectomy, radial, and all, with that cluster, all the factors, they created 4 clusters. And this is the machine learning. You say, well, let's go to the main, run of the mainstream, which is the cluster 1. Average volume, average acuity, average complexity, average use of contemporary devices. So that's one cluster. So let's create additional clusters which have one standard deviation. Cluster 2, average volume, but low acuity and low complexity and low use of contemporary technique. Atherectomies, IVUS, imaging. Cluster 3 is a low volume, but high acuity. Take care of more STEMI patient, low complexity, low use of contemporary technique. And cluster 4 is the high volume, high operator, complexity, high use of contemporary technique. So if you really think about, you say cluster 1 is the average, cluster 2, our low volume operator, simple cases. Cluster 3 is the low volume, but patient they're taking care of the STEMI patient, they don't know much about more contemporary devices, the imaging and so. Cluster 4 is the high volume, high complexity, but doesn't take care of more STEMI patients. And so I put myself in the cluster 4. So idea was that if you compare with the average mainstream, cluster 1, do you have a different outcome? So they went through this very agglomeratic hierarchical clustering algorithm and came up with 4 different clusters with number of operators. You know, this is over 3 million PCIs, and clearly showed that cluster 4 do more PCIs each person compared to a individual. More operators actually are in the mainstream, as we know, and volume of the cluster 4 is much higher than others. Cluster 3 was the lowest, as we said. And then the presentations point of view, the cluster 4 people doing less STEMI. The more important is complexity. Cluster 4, if you see, higher radial access, higher use of IVUS, FFR, atherectomy, mechanical circulatory support, all are plus in these cases, with the left main, more left main being done, more bifurcation, and lesion in the graft, CTOs, all much higher for the cluster 4, which is high volume, more complexity, use of more the technical devices. And this is associated with different in the mortality, as you can see that the cluster 4, and they put it together, that you see cluster 4 better than cluster 1, and really looks like a black always to the left of this, that better in hospital mortality compared to our cluster 1. Same also for various other procedures like procedural success, the bleeding, vascular complication, contrast volume, inappropriate PCI, and so. So authors basically concluded that there is a distinct percutaneous coronary intervention operator profile, differentially associated with patient's outcome. A phenotypic approach to physician assessment may provide actionable feedback for the quality improvement. So clearly you need to take care of the complex cases once you are ready to do them and you have a skill set. So let's sum it up. The final IFR of more than 0.95 improves 1 year MACE rate. 3 thumbs up. IVUS guided PCI to improve mortality in long lesions. 3 thumbs up. Clinical and non-invasive test for left main CAD. Thumbs down. You need an anatomic. We learned that from schema trial. And the jail side branch wire to improve PCI outcome is plus minus. Plus actually I put a very small because it was just only the restoration of the side branch flow once it went down. Otherwise there was no difference. And of course, we know that long-term outcome were not different. So then the simple novel machine learning from the NCDR database has identified 4 different operator profiles associated with diverse in-hospital outcome and mortality. Mainstream and risk electives. Operator have average outcome, but acute excess operator with infrequent use of contemporary technique having worse outcome, while highly complexity operator with greater use of contemporary technique have better outcomes. The simple analysis can help physician profiling for advanced coronary intervention for reporting of highest safety and high quality. I would say this is the first kind of paper which really identify that complex operators having, despite complexity, because they are using more devices, more complex cases, yet have a lower mortality. So that is very, very reassuring, and that's what has been. Like Sinai, we have more complex cases, and we have been with the state for the for ACC and CDR. The acute our MACE in hospital MACE was 0.4% compared to 2.4 for the national, and same thing for the New York State consistently has been a very low and with getting the double star. So let's go to questions. Is the false statement about the results of 1 year defined by trial. One, IFR of more than 0.95 associated with a lower MACE rate. IFR of less than 0.95 associated with higher MACE rate. IFR of 95 associated with higher TLR. About 25% patient post PCI has IFR of less than 0.89. Majority of low IFR is due to focal lesion issues. Here, clearly, we all know, see, IFR of more than 0.95 is associated with not higher TLR, rather low TLR. Then following statement is false regarding the results of the left main CAD prediction in the ischemia trial. Exercise test is a poor predictor. Nucleus test is a poor predictor. Clinical characteristics are reasonable predictor, but not good. LMCAD of more than 50% were excluded from the ischemia trial. And anatomic factor by CTA has poor prediction for left main CAD detection. Wrong. It is the anatomic factor by CTA is the one which diagnosed the left main CAD, not your clinical or other non-invasive test. And the lastly is the following statement is false regarding machine learning analysis of physician profiling. Different profiles have diverse in-hospital outcome. Total 4 different profiles could be identified. Mainstream operators have average in-hospital mortality. Highly complex operator have higher than average mortality, and use of contemporary technique is also with a lower mortality. And answer is D, that high complex operators do not have higher than average mortality, rather they have lower than average mortality despite more complex cases because they are using more contemporary technique and more high risk complex cases. With that note, we finish our presentation for this our CCC Live.
Two final comments from me. First of all, to Anu, this has been a remarkable case of showing just about every technique you need for handling a retrograde CTO. Beautifully demonstrated, just outstanding skills. So my congratulations to you. Second, Samin, a quick rejoinder to your lovely review of the cases. This is just the beginning of the application of artificial intelligence. All you need here is massive data, the almost 3 million cases. You just need to classify it, and the machine learning algorithm provides you, churns out this data in 15 minutes. I think this is just the beginning. We'll have much more to add. Anu, final comments from you, and congratulations once again.
I just wanted to probably show the
We can't hear the doctor.
again.
Yeah. Perfect. Go ahead, Anu.
Yeah, we can show the wires again, because this is a retrograde case with the wires that we used. Newer wires, I mean, cyan black and SUO3, both of them we tried, and the one that actually went through the the septals and reached the LAD was the SUO3, which you see there. Why it is called 3? The tip load is 0.3. Yeah, high load. That's what you can see. So both of them, they're not tapered, 014, and they are already, their preferred use is also says is septal navigation and surfing the septals in the tortuous vessel. Exactly what we saw in this particular case that we had. I mean, cyan black was also tried, but each case is different.
But
Then
the way the
back
SUO3 worked like slip coat, as if like wire slipped. Remember they had the slip coat of 52 centimeter. Once you went, it like slipped into the
in the
branch.
last one's case, the black also did the same thing, because that's also, you see there, the tip load is less, but polymer jacketed and hydrophilic. So that also. So I think all depends on what the anatomy is. Then the next one. Where's the, okay.
Yeah.
Fielder FC and Fielder XTR. We did not try the Fielder XTR, but we did try Fielder FC. It's exactly like Fielder, but a lower tip load that you can see there with hydrophilic coating. The XTR is the one that is tapered. You see that 0.01 to 0.10 and tip load of 0.6 with same hydrophilic coating and polymer jacketed. This again they say is for CTO retrograde to be used for septal surfing. So I'm just going through all the wires so that people know what each wires are meant for, and of course the Fielder family wires which we gone through, and RG3 is the one that we use today. As you see, that as hydrophilic coating, it behaved like that, and we felt that the wires, its diameter is 10, not 14, so we felt may not have enough support, but it behaved beautifully in the entire case. And 330 length, I think very easy to remember. 333 tip load is 3 grams and 330 centimeters with the hydrophilic coating used for externalization once we cross the retrograde. Okay. These are the wires that I think these are just the Fielder wire which you can go back and you can learn a lot. Actually, my fellows, the young attendings are saying they probably will need 2 years to go through the entire app. There's so much details of each wire that is mentioned in that particular app.
And the amazing part is how much updating and effort it requires. Anu, thank you so much. Samin, outstanding case. Congratulations to the entire team. We stop here and we'll see you next session on April the 19th.